Hi, this is Judith Karaksoni and Manos Brilakis, and this is case 211 for the Manual of CTO Interventions. This is a case of acute thrombosis during CTO PCI. The patient was a woman who presented with significant angina due to a circumflex chronic total occlusion. She did have a normal left ventricular systolic function and, as expected, reversible ischemia. Dual injection demonstrates the CTO of the circumflex. There is a blunt proximal cap, length approximately 20 millimeters, diffusely diseased distal vessel, and we do know that the circumflex CTOs can be fairly tortuous vessels. The vessel distally was filling mainly via epicardial collaterals, which did not seem to be very good for the retrograde approach. So the primary crossing was with Antegrade wiring, followed by ADR, and if nothing worked, then we would perform additional injections to visualize the connections for potential retrograde approach through epicardial collaterals. We started Antegrade wiring. This is a turnpike LP. This is an injection through the LP to try to visualize, but actually the turnpike was inside the ramus branch, was not in the proximal cap. So we redirected the microcatheter into the actual circumflex, and then I used a filter XTA wire. And this is where we are. On contralateral injection, we see that the XTA is actually in the extraplaque position. What do we do next? The options here are to pull the wire back and redirect, or leave the wire where it is and then do parallel wiring. Or the third option is to stay where the wire is, advance a reentry system, the Stingray in most cases, and then perform reentry. In this particular case, we decided to try to redirect it, so we tried with a stiffer, more torqueable guide wire, a Gaian X3, that seemed to advance along the course of the vessel. However, when we did the contralateral injection, we see that we are still in the extraplaque location. So contralateral injection, dual access is critical to know where we are. So we decided to bring a Stingray and perform reentry. And this is a Stingray. It was a little further down, so we decided to bring it back a little bit. And then now we are in the more proximal portion of the vessel. So we did the stick and swap technique with a Gaian X2 to stick and then a Gladius Mongo for swapping. But unfortunately, it did not work. We tried different guide wires, the Astato 20 for performing the stick and the Gaian X2. And then we did try a Pilot 200. And then, actually, interestingly enough, the Pilot 200, which seems to be actually exiting not from the main side branch of the Stingray, did go into the true lumen as confirmed by contralateral injection. So we predilated, we put a wire in the more distal part of the vessel, and then we perform intravascular ultrasound, and we see that there is diffuse disease in the distal portion of the vessel. There is some calcification, although it's not circumferential. And then as we move more proximal, we see that we're partly in the true lumen in this location, but then as we come more proximal, again, we're true lumen here. And this is the more proximal part of the vessel that seems to be a little larger. So we do have a vessel that measured 2 millimeters distally and 3 millimeters more proximally, so a big step down. So of course we want to size for the distal vessel and then post-dilate to match the proximal reference diameter. We did place a 2.0 by 30 millimeter drug-eluting stent, and then post-dilated the stent with a 2.5 and 3.0 millimeter balloon, and then did some distal balloon angioplasty for improving the outflow. And that restored good flow into the vessel. However, there was residual disease into the circumflex, which is not uncommon in these CTO vessels. So we did place an additional drug-eluting stent, essentially all the way from the ostium of the circumflex to the first obtuse marginal branch. So nice result there. There was an intermediate lesion in the ramus, which was not significant by physiologic testing. And we were about to be done when the patient developed chest discomfort as well as the segment elevation. And when this happens, the first thing we should look for is the donor vessel. Now here it turns out the CTO and the donor vessel are actually perfused from the same guide because it's a circumflex, the CTO vessel, and here we do have the LAD that has a filling defect in the middle segment. At this time, the ACT was 271, so it had decreased a little bit. We typically want to have more than 300 for antegrade cases, but still, it was not too low. So this came as a surprise. And it's still unclear to us why this happened, but the leading hypothesis is that some thrombus likely formed inside the guide catheter and then embolized distally. So what to do for acute thrombosis? Fortunately, we're able to wire easily and then did thrombectomy with the Penumbra system and gave vasodilators, adenosine, nicardipine, as well as phenylephrine through the vessel. And after doing that, we were able to get a nice result. The thrombus was essentially removed, and the patient recovered TIMI3 flow, and ST changes and chest discomfort resolved. So many lessons from this case. The first one is that circumflex CTOs can be complex. It wasn't too bad in this case. It was extraplaque, but actually they can be complex. The double ply stick and strap can be a useful technique, although here it looks like eventually we were able to get to true lumen. And then when you have sudden ST segment elevation during CTO PCI or actually even non-CTO PCI, the key thing is to check on the vessel and check for dissection thrombosis. Is there a vessel that is closing up, causing this EKG changes and chest pain? And you want to do this quickly because especially if this is a large vessel, hemodynamic compromise and possibly cardiac arrest can come next. So in this case, the culprit was the LAD, which was not actually the target vessel. We did not have any stents there. Nevertheless, the patient developed acute occlusion, partial occlusion. And this is unclear as to why it happened, but it is quite possible that there was some thrombus into the guide that embolized to the mid-LAD. How to take care of the problem? Check the ACT. It was slightly low. We gave more heparin. Then we gave 2B3 inhibitors, did aspiration with the Penumbra system, and gave vasodilators. And that resulted in resolution of the thrombus and a nice final result. Thank you.